Good afternoon to our dearest viewers from wherever you are watching us. Thank you very much for joining us today. I would be your host for today's interview, and I am Fatoumatta Sarjo, a final year medical student from the University of the Gambia. Today, I am going to be interviewing a profile individual who has made a remarkable research on the topic effects of health education on spousal knowledge and participation in birth preparedness. And this was conducted in Farafenni Regional Hospital. So before going further, I would like to have on board Dr. Tunkara. You are welcome on board, ma'am.
Thank you, Sarjo.
All right. So before we get into the interview proper, could we please know who is Dr. Tunkara, please?
Thank you, Sarjo. Before introducing myself, I want to say Assalamu alaikum to all listeners and viewers. I am Dr. Haddy Bah. I'm a senior lecturer at the Department of Nursing, the University of the Gambia. I have my PhD in reproductive and family health. So my specialty area is more of reproductive issues and family health issues. I'm married with four children. Thank you.
Amazing. So what I get from that is we are dealing with a mom, a doctor, and also someone who is passionate about reproductive health. Thank you very, very much, ma'am. So without further ado, I think we can just get into the interview proper. And for some reason, I'm really, really excited because your topic is just such a worthy topic, especially considering the setting that we come from. So my first question to you would be, what motivated you to conduct this research in the first place?
Thank you very much. That's a very important topic. If you look at the Gambia, our culture is a male-dominated society where men decide when and where their wives seek medical care, including pregnancy and delivery care. And studies have identified that most of the maternal mortalities are occurring as a result of the three delays. And these are the delays in making the decision to seek healthcare, and delay in reaching healthcare, and the third delay is delay in receiving care. So the decision making is very, very important. And who makes the decision? These are men. So this is why I decided that it is important to test an intervention in which you help educate men, you invite them to the clinic, help educate them about the birth preparedness, and see whether they will participate. And that can be a guideline, a guiding point, so that further interventions can be done to involve more men on the healthcare delivery relating to maternal care. Thank you.
Great. So this, like what you've said, is actually very important. We live in a male-dominated society, to be honest, because we have seen instances where a woman needs a certain health care to be done for them, but they wouldn't even give you the go-ahead until their spouses or their husbands are present. So I very much agree with you on that. So with regards to the research itself, what do the findings mean for spousal involvement in the care of their wives? Like, what do the husbands tend to get from this research at the end of the day?
Very good. Yeah. When I was developing the intervention, I made a lot of literature review, and some of the literatures are indicating that men, if we invite them, they will come. Others will say that they will not come because of our situation, like they are involved in the work. They are the people who should provide the economical needs of the family, so they are too busy, and our scheduling, our clinical schedule doesn't allow them to participate. So if you conduct this study, there is likelihood that you will not have much participant. I said yes, but let us just see whether it will work. So these findings has shown us that despite the busy schedules of men in the Gambia, if you provide them time, if you invite them, they will come. They are willing to participate. And if you teach them, they can understand and they will utilize the knowledge. So this is very, very important. Men in the Gambia are interested in being partners in the care of their wives during pregnancy and delivery. So that is the message for the
Thank you.
husbands, that they really, uh, despite a lot of cultural issues, if you invite them, you enlighten them on the need for them to participate, they will do that.
Thank you. I love to hear that statement. Men are willing to be partners. So maybe what we need to do more is just to make the path to being partners easier for them as well. And I'm glad that your research is going to set a ground for more of such researches to be done. So that brings me to my next question, which is purely something I came across whilst going through the article. So there's a part that stated that the National Demographic Health Survey of 2019 indicated that Farafenni had a maternal mortality rate that is twice higher than that of the urban parts of the country. Now, if you look at the Gambia as a whole, it's actually a very small country. So if Farafenni and surroundings are experiencing a maternal mortality rate that is twice the number that we experience in the urban areas, it's actually something that is significant. Like we would always say, when we talk about maternal mortality, we are not looking at the numbers, we are looking at every single life that is being lost. So I would want to know, what do you believe is the cause for the number difference in terms of maternal mortality in Farfanya and surroundings compared to the urban areas? And after you have conducted this research, can we count on the fact that if more health education is done, would this be a solution for the maternal mortality?
Thank you very much. That's a very important question. Why the high maternal mortality rate in the rural area compared to the urban? Let's say that every maternal death, even a single maternal death, is a concern, is a problem. And uh, the national maternal mortality of the Gambia is high. Is high. Uh, but if you compare it to the urban areas, you compare the rural and the urban areas, it's even higher in the rural areas. You're asking the question why. We will go back to the three delays that I've already mentioned. You talk
I can
about
hear you
delay.
clearly, Ma.
You're talking about delay in receiving care, delay in making the decision, delay in reaching the care. Delay in making the decision, it goes back to the
Sure.
awareness, knowing about the seriousness of the disease, of the condition that the individual is facing. Like if your mother is bleeding, uh, the family, do they appreciate the danger, the seriousness of a woman who is pregnant and bleeding? So that appreciation, the recognition of the seriousness, will also guide them on the speed that they make the decision to rush the individual to the hospital. And also, if you go to the rural areas, you talk about the educational level, especially among women, is lower. Then you talk about the transport, delay in reaching the healthcare service, the transportation, the poor road network, and sometimes the distance between the villages and the healthcare facility is too long. So that can also contribute to the delay before they reach the healthcare. And when they reach the healthcare system, uh, you go to the rural areas, most of the time you talk about the quality of the care, the expertise, um, the highly trained nurses and midwives, even including the doctors, you'll find more of them in the urban areas compared to the rural areas. So it is multifaceted factors. We talk about awareness, we talk about access, and even the quality of care. All of these things are contributing to the high rate of maternal mortality in the rural areas compared to the urban areas. But as I've mentioned from the beginning, the Gambia as a country, the maternal mortality ratio is even high, but it's higher in the rural areas, and it is a cause for concern. Thank you.
Thank you very much. So I hope people are actually listening to that because sometimes we tend to find ourselves in societies where people tend to make it look as if we are not doing enough. But for someone that is an expert in reproductive health, I'm glad that you're communicating that when it comes to maternal mortality, we don't even look at the numbers. We just look at every single life that is lost because each life actually matters. So that brings me to the other question. So as part of your intervention, I understand that the assistance of persons that are knowledgeable in the culture of the people were actually made use of in order to make sure that health education modules and visual aids were designed to reflect the community's characteristics and traditions. Now, the emphasis here is on the community's characteristics and traditions. Why do you feel it is very important to incorporate the ways of the people in what you are doing?
Yeah, this is very, very important because when we were making our modules and our visual aids, the posters, uh, we had to find somebody who is very knowledgeable on the culture to guide us. Because if you talk about reproduction and male participation, there are a lot of cultural beliefs in it. And whatever interventions that you want to do, it should reflect the people's culture so that they can understand it and they will accept it. So that was the first thing that we did. We were also trying to find out what were the cultural barriers that determine from participating. And we identified that many a time in many of our cultures, they believe that pregnancy and delivery is the role of the women. We talk about gender roles. So when we were developing our this thing, our questionnaires and also our visual aids, we had pictures of women that are with the Gambian culture, Gambian dressing, being escorted by their husband, not a Western people or something. These are women Gambian culture. They wear dresses of Gambian women, and also the husband was a Gambian picture, so that they will know this is about us. It is not something that we invent, or it was invented somewhere else, and we want to bring it for them to use. So we were trying to communicate to them using the Gambian culture so that they understand that it is not a foreign thing. It is part of us. Like a husband assisting a wife to go for delivery, to go for healthcare uh, services, it is part of our culture. It is not foreign. It is just that about the beliefs and the barriers that we need to talk to them to understand the importance. So that's why really we work on that, and it paid dividend in our interventions for them to accept what we were educating them on. Thank you.
Thank you. I like the part where you said you actually made use of pictures of our own people and not, let's say, pictures of white people where it looks as if it's something imported. So if I'm seeing a black person, someone I know on this platform, I know that this person is one of our own. So my concern there is, were you using stickers, as in emojis and the like, or were you using pictures of real people? And did you face any sort of restriction if, in case, you were using pictures of real people?
No, we were not using pictures of real people because of the ethical issues in it.
Okay.
Like,
Okay.
yes, we were not using pictures of real people because, you know, prior to the research itself, conducting the research, we submitted the proposal to the Gambia government and MRC ethics committee for them to review. And those are ethical issues that were really looked at, the privacy and the confidentiality of people. So they reviewed our this thing, our posters alongside with other things, to be sure that really it was something that did not expose people's identity in the study. Yeah.
All right. So still on incorporating the ways of the people or the tradition into this research. You said it definitely paid dividend, and I would want to agree on that with you. What is one positive impact that stood out for you out of the fact that you actually incorporated the ways of the people?
Thank you very much. Yeah, because one of the things that really came out was that when we were talking to them about the importance of them escorting their wife and participating in the delivery, that is male participation in the delivery of their wives, they were concerned. Some of them believe that if they enter the delivery ward and the the blood of the woman who in labor touches them, it can cause impotency in them. That is part of their belief, their cultural belief. But the pictures that we had, they saw male nurses, male midwives, and even during our intervention, I had six no, research assistants. Four of them were male. Four of them were males. So that was number one thing that we work on. That these people are in the labor ward. They are working there and they are the one performing delivery. And the bloods are always touching them. They have their wives and they have their children to clear their doubts. And it paid dividends. So we are saying how that these people are working there. They are married. They have their family. They have their children. It did not cause any impotency in them. So it is the same thing for you. You can enter the labor ward, that blood can touch you, nothing will happen to you. So it help to clear their beliefs against participating in the labor care. And also some of them believe that it is not good to prepare for a child who is yet to be born. It is not good because it can cause bad luck. So we had a video, and that video, we got the video from Jame Foundation. They already had a made participation program. We got that video, and that video was showing people that were participating, and they were also explaining the importance of participating or preparing for the birth, so that it helps to prevent a lot of the delays. So all of these things helps to clear their doubts, and also to know that some of the things that they believe on were just misperceptions. They were not correct things, and it will never have any impact on their health.
So thank you very much, Doc, once again. So if you are just joining us from anywhere, be reminded that today's interview is on effects of health education on spousal knowledge and participation in birth preparedness, a research that was conducted by Dr. Haddy who is a reproductive health enthusiast, and this was conducted in Farafenni Regional Hospital. So I am your host today on behalf of the Gambia Center for Research and Policy Studies, Fatoumatta S. Sarjo. So moving on to our next question, I would love for us to take a quick look at the overall methodology that was used for this research. So I've been made to understand that initially you had 300 participants and sampling was done, which you ended up having a final number of 150. At least that is what came in for the first session. Am I right?
Yeah, the whole sample size was 350. We had two arms. We have the intervention arm and the comparison arm. The intervention arm was the group where we administered the intervention. That is, we gave health education on birth preparedness, male involvement in birth preparedness, the importance of birth preparedness, including blood donation. We counsel them to donate blood. And also we have another group, which is the other arm, the comparison arm. That group, we did not administer the intervention. We just gave them a placebo, which was a health education on maternal nutrition during pregnancy, and exclusive breastfeeding. So in the two groups, we have 150 participants in each of the groups, making it 300 participants from the beginning. But later on, when we are doing our post-test, there was some dropout both in the intervention and in the comparison group. We end up having lower than 300 at the end of the study. Thank you.
All right. So my concern actually was I felt as though 300 was quite a high number. Would it be right for someone to say we had like 300 pregnant women or ladies within the caching time or within the study time frame, right in Farafenni and surrounding areas? Is that what is being implied? Because I personally felt like 300 was quite a lot of females.
Yes, yes. Our target, the beauty of this study was that we were not targeting the female. It was their spouses, their husbands. So when they came for antenatal booking, we identified them and we gave them invitation letters to give it to their husbands. And they were also uh, oriented on the research. And if they accept that their husband can participate, we gave them the invitation letters for them to come. So that's what we did. And the recruitment took about 4 months. It is not 1 month thing. It was a 4 month, and we were just recruiting them and administering our intervention. So it was a 4 month study. Then also we have a follow-up to see whether they participated in the bad preparedness or not. So the study was about 6 months as a whole.
So with regards to the first and each had like a 25 minutes one-on-one session. So how many people were actually discussing with these 150 spouses that you had on ground? Because again, if you do all of the maths, I feel like it was going to be too time consuming. So it couldn't have been one or two individuals. So if you could clear that end too, because like I said, your research is going to be a ground on which we would likely have more other such researches coming on. So it would be important for the public out there to have a perfect grasp of the methodology that was being dealt with when this research was going on. So if you could clear out that portion for us as well.
Very good. As I've mentioned earlier, we have 6 trained research assistants, and 4 of them were community health midwives. The other 2
Great.
were state registered midwives, and we had 4 at the antenatal clinic and 2 at the labor ward. So the four participants at the antenatal clinic were the one administering the intervention. And the way that we were doing it was that Farafenni at their R&D, that's where they provide the antenatal care. Normally, they don't have antenatal clinics on Fridays. So we were using Fridays for the intervention. When these healthcare providers, the community health nurses, they are also working in the antenatal clinic. That's the time that they are free. They are not providing any other care. So basically, from morning till 2 o'clock, the only thing that they do on Friday was just to give face-to-face health education to the spouses that were coming for the intervention. And for the comparison group, we were doing it on alternate Fridays. Like if this Friday is for the intervention, then the next Friday will be for the comparison group. So we were sending them, we were calling them and also sending invitation letters through their wives when they come for clinic. So that was the way we did it. It was 4 research assistants that were administering the intervention, both the interventions and the comparison group, and we used Friday when they were not occupied.
Amazing, amazing. I mean, this is what happens if someone is doing something they are already conversant with. Because if you look at the fact that you guys were alternating the days on which you actually had sessions with the intervention group and the comparison group, it's like there was no chance for these 2 groups to actually mingle and share their discussions, right? So at the end of the day, the post test was going to make more sense. Now that actually brings me to my next question, because we have seen That was a point that mentioned that not everyone actually obliged for them to be part of the whole study or the whole research. And we had like 61 spouses that were excluded. And out of the 61, we had 32 that were excluded based on the fact that their wives didn't want them to be participants in the study. Right. So that makes me wonder, did these women give any reason why they didn't want their husbands to be part of this study? Because on a normal basis, we are expecting women to want their husbands to be by their side, to be their partners in terms of the partum period, right? Their antenatal period all the way to delivery. So I don't get why these women wouldn't want their husbands to be part of this. If there were any specific reasons, kindly take us through.
No, the women were not our target. The only thing that we are involved, we have to have their consent, because it's about them. They should agree that their husband can participate in their care. So that was why it was part of our inclusion criteria. That as it concerns them, is about their care. Before we invite their spouses to participate in it, they have to consent. So after when they came for booking, we identify them, and we talk to them about the study. We clearly explain the purpose of the study and what is required in the study and for how long, the benefits and the risks involved. And we gave them the opportunity to say, yes, I want my husband to participate, or no, I don't want my husband to participate. But I think definitely that's part of the limitation of the study. We did not go further to find out why they are not interested. The only thing that we did was that we explained to them the importance, the benefits, and also the risks, and we gave them the power to decide on their own whether they want their spouse to participate or not. Those that consented and said, yes, I want my spouse to participate, we gave them the invitation letter. But the ones that refused or rejected, we did not go further to find out why. Because they are where the story
Great.
stopped with them. Yes.
All right. So I think that would be one of the points where, let's say, in the future, someone else wants to do a similar study. It would be important for us to know why these women are actually rejecting. Because I kind of tend to look at it like, let's say, family planning, for example. You tell some women about family planning and they would reject it outright. Then you ask them why, and sometimes the only reason they will give is because my husband does not like it, and that's just it. So for us to actually know where else we are supposed to go from here in terms of help in such situations, we need to know the reasons that are backing their decisions. So I'm glad you've actually highlighted that as a delimitation, and hopefully more people will actually look into that area, so in case we have anyone doing such research in the future. So moving on, as part of the intervention group, blood donation was something that was highlighted. They were counseled about blood donation and actually referred to donate blood to make sure that if their wives find themselves in situations where there is an emergency need for blood, then blood would be readily available. Did you face any challenges in that regard? Because welcome to the Gambia, we have spouses that would tell you, I don't have much blood, I cannot donate blood, or reasons like that. So did you face any such challenges?
Yeah, we faced a lot of challenges in that. And even if you go through the research, you find out that that was the area that we did not have much increment compared to the comparison group. Yes, we counsel them on the importance of donating blood. And we even made arrangement with the blood bank at the hospital that when we refer them, they'll take their details and that of their wife. And we assure them that despite the fact that we will not give your wife the same blood that you are donating, it's just similar to the banking that you are doing with money. Like if you go to the bank, you deposit your money. When you want to cast your money again, it's not the same money that you deposited that will be given back to you. So, but we'll ensure that if you donate blood and bank it with us, whenever your wife needs blood, similar to what happens in the bank, whenever your wife needs blood, that blood will be available. It's just it's part of the bad preparedness. That's what we call the emergency readiness. and we canceled them. Most of them appreciated the importance of donating blood, but transferring or translating that appreciation to action was a problem. Some will tell you that at this moment, I don't think that I'm that strong enough. I am not feeling okay. I will go and come back
Wow.
later. Some will tell you that definitely I'm afraid to give out blood at this moment. Let me just go and see whether my brother, who is younger than me, can come and donate blood. So it
Wow.
was a problem. And even they were invited in the second session, we repeated the counseling and referred them again. But very few of them donated blood. So there are a lot of problems
So
in motivating men to donate blood for emergency preparedness. And I think that's an area that people need to research on, how to motivate men to be
honestly,
donating blood and bank it with the blood bank so that in the event that their wife needs blood, that delay in interventions will not be there, because you'll see that sometimes women will need blood, urgent blood, but there's no blood in the blood bank and it delays the intervention and it can cause the life of that woman. It is not the fault of the hospital. We don't buy blood. The blood should be donated. But if it is not coming forth, where will the hospital have it? So that's the issue that we are facing. And whoever is with us today or will watch this video, please, this is an information for everybody. The hospitals need blood. And we don't buy blood. It is the blood that we donate that the hospital can use to give it to women during emergency. So if you don't give it out, just like in the bank, if you don't save money in the bank, you cannot go there to cash money. So that's the issues. That's the issues. And really, we face a lot of problem in that part. Thank you.
emphasis on we do not buy blood. I cannot emphasize that enough because that tends to be the rumor we find in the societies that you need blood and the hospital does not even have blood. So the blood that are given to your patients are blood that have to come from other human beings whose blood match those of your patients. So unless and until there is a blood readily available, there is no other way we can manufacture blood. We don't manufacture blood. It has to come from people. So I think that's an important message you've passed there. So based on your own experience and your own individual perspective or opinion, where do you think the gap is? Because I would have thought maybe there is less counseling, just maybe. But considering the fact that you had actually counseled these people on 2 occasions, but they were still not forthcoming, where do you think the problem lies? I still don't get it.
I think still is about it's about awareness. I believe that despite the fact that we cancel them, but let us appreciate that knowledge is not something that you easily translate to action. There, it is a process. It is a process, and also it needs confidence. Like some of them, after canceling them, they will tell you that, what about if my wife does not need it? What will you end up doing with that blood? And we made them to understand that if your wife does not need it, we'll give it to another woman who needs it. And that means that you've saved somebody's life. And uh, sometimes, some people believe that people working in the hospital do sell out blood. So they will tell you that if my wife did not need it and it end up being sold out, what benefit will I gain from it? But I want to make it clear. In the hospital, we don't sell blood.
Well,
We don't sell blood. And donating blood for emergency preparedness doesn't mean that your wife must have it. If your wife does not need it, we'll give it to somebody else who needs it. And in one way or the other, it means you have contributed in saving somebody's life. And that's a plus for you. So that's one of the
honestly,
issues. The
honestly.
confidence of the people on the services that we are providing is important. And also, we need to keep on reminding them increase in knowledge does not easily translate to behavior change, it needs persistence. Because really, some of them were just thinking about it. They were a little bit reluctant from the beginning, but in the end, in the second counseling, some of them went into donate blood. So I believe that if that was something that was on, That anytime that they are invited, they are reminded on the importance. Then you'll see that, in any society, if there's any changes, you see you have early adapters, people that can easily adapt it to it, but you also have late adapters. So these late adapters needs persistent motivations, persistent reminding them so that they can easily adapt to the a new desired changes that you want them to do. So that's the thing. And let us also remember that in the Gambia, we have a lot of cultural beliefs about donating blood, because some cultures may believe that if you take out this blood and like, we have this class system. I am gay. This is one is a gay well and the like. These class levels, and some of them may believe that their blood should not mix with somebody's blood who is of this, who is not of the same class. I'm not saying that this is the main thing, but from my experience as a Gambian and as somebody who is a little bit knowledgeable about the culture, this might be some of the issues that are also contributing to the people's unwillingness to donate blood, because they may believe that maybe if you have of a higher class, if you donate blood, it may be given to somebody who is of a lower class, and your blood should not mix with somebody's uh, who is not of the same class with you. And these are some of the things that we need to understand. Some of them believe that uh, if you give out blood, it may have an impact on your health. These are all misconceptions that we really need to be talking about, and it needs persistence. Let's remember that these are behaviors that may not be changed in one day, because it is already part of us. Thank you.
Wow. That is something new for me, honestly. To think that someone would be thinking because they are of a certain class, their blood should not mix with that of someone from a different caste system within the society. Wow, that's news for me. But like you said, I just wish that this info could get out there, and more of a message to the National Blood Transfusion Services that we definitely need more work to be done in terms of blood donation. We cannot do without blood. Women cannot do without blood, because when they're given birth, they already lose so much blood. So there has to be a way to have ready services, institutionalization, improved healthcare in terms of blood donation. And hopefully we have more initiatives in that regard. But thank you very much for making this known to the public. So with regards to my next question, so I'm sure there's a reason that you had an intervention group and you still had a comparison group, because there's something you were looking into, there's something you were looking for. So comparing these two groups, what were the pregnancy outcomes like for those within the intervention group and those within the comparison group?
Yeah. The outcome of that pregnancy is another study. It's not part of this study, because this study, the main purpose was to test the effect of health education on spousal knowledge and participation on birth preparedness in Farafenni. That was the purpose. And I want to just seize this opportunity to thank the University of the Gambia. After this study, I was sponsored by the University of the Gambia to conduct another study to find out the
Amazing.
effect of spousal participation in birth preparedness and institutional delivery on birth outcome. We did that study. We analyzed the study, even though it is yet to be published. So that's why I did not submit it. Uh, uh, but the effect of these interventions on birth preparedness was measured. It was not measured in this study. It was measured in another study, because the main purpose was to check whether if you help educate men, they will know about birth preparedness and they will participate. That was the aim of this study.
All right. So, but at least I understand that their second session with you was somewhere around 36 weeks of gestation of their wives, right? So at least could we know what you found out comparing the intervention group, that is knowing that they have gone through all the necessary counseling in terms of birth preparedness, compared to the comparison group who weren't prepared in that manner? What was the main difference between these two groups in terms
Thank
of
you
birth
very much. There
preparedness?
was very good. There was a very significant difference between the comparison group and the intervention group in terms of their knowledge and participation in birth preparedness. The participants in the intervention group were 4 times more knowledgeable and more likely to participate in the birth preparedness. And in the bad preparedness, we were talking about buying the required materials. They were taught on the materials that they should buy, including buying the part, buying underwears, at least two underwears for the wife, buying the clothing and the wrapper for the baby, and also for the gown for the mother, and also they need to have a bucket where they can put the placenta and the membranes, the products after delivery safely, and also saving money in the event that there's any emergency need uh, during pregnancy and also delivery. Identifying transport, that was also very important. We were not specifically talking about vehicles or any other thing. We were talking about the transport that can be easily available. It can be a donkey cart, a horse cart, or a vehicle. So if you don't own any of them, we advise them to identify somebody who lives nearby them and discuss with them, allow them that in the event that my wife went into labor maybe late at night, let's just say that you don't have any donkey cart, you don't have horse cart, and you are in a remote village. Your wife is in labor at 2 o'clock. You do not make any arrangement with anybody. You find it difficult. And it can cause delay in reaching the healthcare. So working with somebody to ensure that you prepare them that there's possibility in the event that I knock at your door anytime late at night, know that I may need a transport for my wife, so that you prepare them. So those were the things. And you will see that those people that were in the intervention group were more likely to perform those activities compared to the ones that were in the comparison group, because we did not teach them on those things. So this means that if we inform men, like during during antenatal care, when we if we invite them during the booking of their wives and we talk to them about the needs of their wives and prepare for their births, they will do it, because many of the interventions, they were 4 times more likely that they were prepared. They bought it, and we were sure they bought it, and they showed us that we were prepared, because they were followed up to the labor ward. I said that we had data collectors, we have research assistants at the labor ward. So those that delivered at the hospitals, uh, the midwives down there confirm that their husbands were able to prepare all those things that we mentioned to them during pregnancy of their wives.
Amazing, amazing. So, the only thing I would have loved to add on to that is I noticed that the comparison group, what they were taught mostly was about exclusive breastfeeding and the importance of nutrition in pregnancy. So even though you were trying to not necessarily talk to them about obstetrics and its signs and how to spot them out, blood donation, etc., I still feel the nutrition intervention is very important. With me on that maybe the intervention group should still have been taught about those two things as well, or were they also taught?
No, the intervention group, we were just, our purpose was to check the effect of health education on spousal knowledge and
Sure.
participation in bad preparedness. That was the main purpose of the study. For the comparison group, research, it has
Okay.
ethics. You cannot invite men, and because it is not a routine for that clinic, they don't normally invite their spouses by then. During the when we were conducting this study, it was not part of their routine. I'm not sure whether now, because we recommended that to start, and I hope they've started. Yes, um, it was not part of their routine. So you cannot invite people to come just like that and you don't give them anything. So that's not ethical. So that's part of what they gained from this study, the comparison group. At least they had knowledge on nutrition during pregnancy and the importance of exclusive breastfeeding, and that's a plus. It was outside the purpose of the study. We did not measure it, but it's what the study provided for them for participating in this study. That's why we call it is a placebo. At
Amazing.
least they get something from it.
Thank you. That's clear enough. And I feel that partly answers my next question, but I would still ask it anyway. So, was this research financially demanding? Did the participants gain any financial benefits from this research?
Yeah, this research, the participants, they did not gain much, We were just giving them transport reforms. Uh, because if you look at it, research, it has some ethics. You should not give them a lot of money that will force them to participate. It may not be ethically acceptable. So we were trying to look at wherever they are coming from to see how much money it can cost them to travel to our health facility to participate in the study. Then we give them transport refund. It was just basically transport refund, but we were not giving them any much money regarding this research. But really, it needs some money because we were paying the data collectors and also giving out the transport reform. So it needs money.
All right. So did you get the financial support that you needed, or were you self-funding yourself?
This research was part of my PhD researches, and I was
Okay.
funded by the by my this thing, my sponsor.
Thank you. And from my end, we would definitely love to tell that sponsor of yours a huge thank you, because this research is definitely worth it. Anything to kind of get our men to come on board and not see delivery or pregnancy as something exclusively for the female is definitely important. So I'm glad that there's a research like this. Just maybe I might be the next person to succeed you in conducting a research of this nature. So well done for setting the ground. Honestly, it's amazing. So with regards to the compliance rate, it's actually remarkable. I was impressed with how much compliance you've had from most of the participants, at least. So what mechanisms were you employing that have assured you such high rates of compliance?
Yeah, one of the most important thing is to ensure that the wives consent to it, and also we gave them invitation letters that well explain what the study all about. And when we were doing that, people were just asking, "What about those people that were not educated?" Uh, it was something that we were checking on, and when we sent this invitation letter, surprisingly, many people came in. So it means that even those that were not educated, if you send them letter, they'll find somebody to read it. So why we were not starting with the phone calls at the beginning? Because we just want to say sustainability. It is a strategy that we believe that the hospital can adapt. So making phone calls can may not be cost effective, but having a piece of paper where you just write few notes and send it to the husband, if it works, it is cheaper than making phone calls. And I can tell you that just writing to them, giving it to their wives to deliver it, even though it may come from areas where you have limited people who are educated, they'll find somebody to read it, because that's what we did. We sent them letters and they came. They responded to our invitations. And let me just tell you that since after that study, even I think it was just few days ago, they're still calling me. Men that participated
Wow.
in that intervention are still calling me, not about sometimes they'll just call me regarding one of the family members is sick. What can they do? What's their advice? Even when they are sick, sometimes they call me for an advice. It was just I think it was just last week somebody called me that my wife is pregnant again and is just vomiting persistently after taking the fancida. What should I do? I said, please take her back to the health facility. So it means that even that initiation of that contact can be a lifelong contact between the healthcare provider and the family members and these men. Sometimes they call me at home when they have health issues to give them advice. What can they do? So this is just teaching us that just having a mere two contacts with these spouses uh, during the pregnancy of their wives can create that that relationship between the healthcare provider and the men in the society. So I hope others in other healthcare facilities will learn from it. Yes.
Impressive. That's impressive to think that some men are still calling you even though the study period has actually elapsed. That's actually impressive, and I think I kind of commend healthcare facilities like Bundung for that. That if you come with your spouse to the hospital as an antenatal, they give you that due. It's like it's a form of encouragement that your spouse has taken their time to come with you, so we give you that level of respect and that level of honor and all. So I'm hoping that after your study, Farafenya would do something similar, because from all that you are saying, it definitely means that the interest is there. It just needs someone to wake it up in the men that we're dealing with. So that's quite impressive. And going through your results, there is something that I spotted. It might not necessarily have to do with the research, but I still feel it's important. And that is the fact that most of the spouses that you've had as participants, their last children were born 2 years ago. So that's like telling us that there is at least a 2 years spacing between their current children and their last children. Yeah,
Yes,
their
yes.
current child, sorry,
I
and their
think
last
that was a,
child. So
yeah.
when you look at that, exactly. So I think exactly. So if you could expand on that, because listen, I personally feel it's important and part of bad preparedness. If there is so much tight schedule between your kids, even the growth and development of your kids is at risk. Yeah. So if you could expand on that, I was thinking maybe their community is receptive to family planning, or is it just a natural method? If you could expand on that, please.
Yeah, definitely. My study did not touch that. We did not look at family planning, but that is something that came out of the study. That at least those people that participated, they manifested a sign of good spacing between their children, and that can be maybe
Exactly.
the reproductive health unit at the RAD is doing well on the family planning. It can be also part of the resource based funding. you know, Family planning services are also funded. So that may be one of the reasons why you've seen that good spacing in this study, despite the fact that it was not part of the objective that we were measuring, but it came out. I believe that it may be the family planning unit is doing well in that area of the country, and also as a result of the resource-based funding, that's why it is helping that in that area. Thank you. That is the RBF.
Amazing. Great. Great, great. So I would agree with you that hopefully the reproductive unit there is actually doing a good job, and kudos for that, because it may not necessarily be something that you intended to pay attention to. But I was impressed to see that we have 2 years bad spacing between kids. That's impressive and very, very laudable. So coming back to the research proper, there is barely any research that is done without challenges. What were your challenges with regards to this research?
Very good. The main challenge that I had was the close supervision. As a married lady, and where I am and where the study was, it was a little bit a challenge because at least in every 2 weeks I have to go there to check what is going on, to check all the data, whether the data has been collected and completed, any issues that they were facing. That is the supervision. It was a little bit of a challenge. And the other thing is tracing them, the contact tracing. Like some of them, we were following them up, like those people that did not, their wives did not deliver in the health facility, or they did not escort their wives during the delivery. For the post-test, we use the phone numbers that we recorded to call them. Sometimes you call them, you cannot get them. And what happened in Farafenni, you'll see that because of the free maternal health care services in the Gambia, some people from Senegal, Farafenni is not far from Senegal, it's around the border, will come and utilize the maternal health services. And sometimes they stay with their family members around those villages. And when they deliver, they go back. So we had problem with those people. Like when they give you call phone numbers, you call them, they will tell you that they've returned back to their village. So that also contributed to the dropout. Some of the numbers that they gave you, when you call them, you cannot get them. And let me just, before moving further, let me just thank Malik. Malik Samba is a community health nurse, was very helpful in that, in tracing some of them. So he was taking his bike, taking their address to check whether he can follow up, to reduce our dropout rate. Sometimes the contact that they gave you may not be the real address. You go there, they'll tell you, I don't know that individual. Especially those people that gave us, those people that were living in Farafenni, they'll tell you that I'm living in this street. You go there, they don't know that individual. You go around, you find it difficult to trace them. So contact tracing was also difficult during our study. Thank you.
Thank you. And Mr. Malik Samba, if you're watching this or if you end up watching it at any given time, it's a huge thank you for your efforts. That is something that is appreciated. And we need more people like you, actually, because just maybe without Malik, the dropout rates could have been more than this. So it's a huge thank you to Malik. And that
Excellent.
gets me to my
Yeah, he
final
really did
question,
well.
ma'am. We are almost at the tail end. Yes. Yes. So my final question would be, are there any areas within this entire subject that we are discussing that you feel more research needs to be done on? And if you could repeat this particular research, what would you do differently?
Thank you very much. Uh, like the gaps, where are the areas that we need to study more? I did mention about why men are not willing to donate blood, really. That's a cause of concern. And what type of interventions can we put in place to motivate them donate blood? I think that is an area that we can look into. And also uh, measuring the impact on the male participation, on birth preparedness, and also delivery, whether it has an impact on the outcome of delivery. Even though I did a study on that, and we found out that it doesn't have an impact. It improved access. Many of the men that we included in our study, their wives delivered in the health facility. And they'll tell you that the wives will tell you that my husband was able to buy all the required drugs that were prescribed for me, anything that is needed. So it increased access to care. But it did not have much impact on the delivery outcome. So that is another area that we also need to look at the quality of care itself. They can come, but when they come, what type of care do they receive? Because that is also very, very important. I come with my bleeding. At what time an intervention was taken will have an impact on the outcome of that bleeding. Because if there's much delay in that intervention, or I have eclampsia, I'm fitting. My husband recognized the fact that eclampsia is a life-threatening and rushed me to the hospital as early as possible. But at what moment was an intervention taken? That's also very, very important. So we need studies that will also intervene to improve the quality of care. So that as we are encouraging men, encouraging them to bring their wives to ensure that they do whatever is required to be there on time. Also, we need to have studies on how to improve the quality of care that we are giving in order to have a positive outcome. So those are areas really that I believe we need to work on those areas. And if I'm to do it again, or what should I do better? uh, is the selection of the participants. You know, I chose only one hospital, and I was just uh, uh, trying to ensure there won't be any contamination. So the comparison group and the interventions group were not coming from the same villages and the town. Like uh, they were coming from separate villages. But that doesn't mean that they will never meet. You know, Gambia, we have our programs, they may meet at Gintes and can discuss issues. So it can easily dilute my intervention. So that's why it can be a limitation of the study. So if I was to do it again, maybe I'll just ensure that I use a separate health facility as an intervention and another similar health facility as a control, so that definitely I'll be sure that the participants and the comparison group and the interventions group, they don't meet at all. So because I am still afraid that there was some possibility, the way Gambian live, especially in the rural areas. However, they may not be coming in the same villages, but they have opportunity to meet. And whenever they meet, there is possibility that Mr. X will say that I've been to the health facility and I was taught about this and that. And they would only say, yes, I have been there, but I was told this and this. And that can easily dilute your intervention. But despite the fact that we've learned something from it, that men are willing to participate, let us ensure that we develop interventions for them. And I also encourage that when we are developing an intervention, it's not only calling them, teaching them, encouraging them to participate or help their wife, but also let provide services for them. That's another thing that I think if I'm to do the same study again, I will provide services for them. Because when we invited them for the health education, some of them, they also have their own health issues. They were calling us at the corner. These are the issues that I'm also facing. What can I do? Some were having some STIs, some were having malaria, some were having anemia, some were even having high blood pressures. We called them to talk to them about their how they could help their women. Basically, it's about health education, but they had other issues. So this is telling us that men also have problems. It is important for us to devise interventions that capture also their needs. Like when they come, you can give them health education on bad preparedness, but also provide an opportunity, screen opportunity for them. Like if you are sending their wives for visiting, voluntary counseling and testing, you do couple counseling so that they can be tested together. If you are sending them for any STI testing, you send them together so that they can also benefit. In the event that you identify any abnormalities, you treat them together. So you will see that most of the problems that we are facing, it can help to break those problems. Like sometimes you screen a woman who is pregnant, you identify that they are HIV positive, but disclosure becomes a problem. Uh, to bring in their husbands becomes a problem. But if you did that together with them during the booking, you cancel them together, they move together. It's a couple thing, couple care. Pregnancy should be a couple care. My specialty is family reproductive and family health. You treat them as a family. You treat them together. You provide services to the couples. So those are the areas that I think that if I'm to do it again, I'll improve on that. Thank you.
Thank you very, very, very much, Dr. Tunkara. It's been an amazing, amazing interview session with you. And I think we have covered everything that we need to cover. Just like you said, men are willing to participate. But as much as we need men to come on board and be who we expect them to be, and that is partners, we also need women to come on board and be who we expect them to be, and that is partners. Men. And with regards to blood donation ad, I think men should also know that blood donation is an opportunity for them to have themselves tested. There is no way blood without us testing you for HIV, hepatitis, etc., etc. Because we need to make sure that the blood that is being donated to the next person is free of any diseases. So that is a free gateway for you to have yourself tested and know your health status very, very regularly. And over and above all of that, humanity. I don't think there is a higher method of being human than donating blood. You're literally just saving the next life, and that life could actually be your own. So this literally brings us to the end of today's interview, and it has been amazing with you. Thank you very, very much for this groundbreaking research. I'm hoping that more people will get to see this video and that research would be very, very accessible to the general public out there. And for those that might be working on blood donation initiatives or any other reproductive initiatives with regards to involvement of men in the pregnancy of their spouses, here is a research that you definitely want to consider. Here is an article that I read and enjoyed, and I believe you would do the same.